Susan is a medical doctor, a public health specialist with over 13 years of experience in leadership roles. She has a passion for clinical mentorship and coaching of staff and is focused on results. And today she will share with us the lessons that they've learned through their project, through her presentation. Over to you, Susan.
Thank you very much for that introduction. Good afternoon, good morning, good evening from wherever you're joining us. Today I'm going to give you a snapshot of what we have been able to achieve. That is the title, Community Medication Refill Program. And this is a rural model program for antiretroviral therapy access for our unstable patients in Kajiado County. This is the outline of my presentation, and I'll give you a short background of our program. So Fahari ya Jamii, which is a Swahili word meaning the family's pride, is a USAID funded project that is working collaboratively with 2 counties in Kenya, that is Nairobi and Kajiado. And the main purpose of the project is to provide county-led equitable access to all general population as well as key populations. So the program as well supports reproductive, maternal, neonatal, and child health, as well as water and sanitation hygiene programs in Nairobi. And we also have a component of COVID within both counties. We started working in Kajiado County since we've been working in Kajiado County since May 2021, supporting 5 sub-counties within the county. So that's a map of where Kajiado County is. It borders Tanzania, and it's a very vast county with both urban and rural areas. So we implemented in 6 health facilities within the county, and the criteria for enrollment of our patients included patients with high viremia of more than 1,000 copies. We had patients who had been categorized as stage 3 or 4 with opportunistic infections under those classes. We also had patients who frequently missed their appointments, and those who are less than 5 years, as well as those who are more than 55 years. So generally, patients who are considered unstable. The selection was done through facility multidisciplinary teams, and we were using a case management approach to manage the patients. So patients were able to choose their preferred drug distribution models during the routine clinic visits as they came. Our main backbone of the implementation involved community ART groups, and we had different models from drug refills to drug distributions, and we were using non-ART dispensaries as well as community manyatas. This is a community of Maasais, and they live in homes referred to as manyatas. We had 3 different models. As you can see on the picture, they are classified as 2. Why? Because the healthcare worker-led model, as well as the works almost similarly to the lay healthcare worker model, where we'd use peer mentors, we'd use mentor mothers, as well as community health volunteers who work at the facilities. We also had an arm that was led by the patients, and this was a peer-led arm. So the community, what formed the background of our implementation? So we realized that there's more evidence for less intensive differentiated models of care, especially for the patients who are stable. The new guidelines call them established patients. We, however, have very few differentiated models that target unstable clients, the clients that I have mentioned before in the previous slides, advanced HIV, those with advanced HIV disease, the viremic patients, the non-adherent, and those with comorbidities. So we implemented a DSD model for these patients that were classified as unstable. How are we monitoring? So we developed a dashboard on DHIS2, And this involved weekly monitoring on that platform, daily with the facilities, and then weekly at program level. We engaged county mentors as well as, and the county mentors were allocated to facilities. We had weekly reviews and feedback, especially with the sub-county and facility teams. And on a bi-weekly frequency, we would have deep dives of the data that we have with the program or the technical team. What were the results? So this is the DDD patients that we enrolled by age and by sex. We had a total of 52 patients enrolled during this phase. So we realized we had more females than males, and 33% of them were children, 0 to 9 years, 19% 10 to 14, and 8% of them were 15 to 19. I'd mentioned that the females were more, 53.8%. So what models did we have? If you look at across the 6 facilities, we had lay worker-led models more than the healthcare worker-led models. And by location, we see that a good number of distribution was happening at the non-ART sites. So looking at the client groups that we had, so we had majority of our clients were 46% were those with adherence concerns, and then we had 31% with viral load more than 1,000. So BCL Health Center is one of the 6 facilities where we implemented. It is in rural parts of Kajiado, that is Kajiado Central, and we enrolled a total of 12 patients. Of these 12 patients, so this is the facility that showed the best performance in terms of appointment keeping. 75% of those patients were on more than 3 months MMD. Again, 75% were females, less than 15 were at 25%. And if you look at the trend of appointment keeping, when we started in February 2022, we were at 45%, and by June 2022, the appointment keeping at the facility, overall appointment keeping at the facility had improved to 80%. We had feedback from some of the participants and beneficiaries, and they reported that the ART distribution could help them quickly access their drugs, and especially those who were prone to default or clinic interruptions. However, this did not come easy and had some challenges in terms of stigma. Stigma index is still very high within Kajiado County. We also had commodity issues around viral load monitoring, CD4 monitoring, as well as serum CRAG. And for that, we were not able to monitor most of our outcomes. As I'd mentioned, it is a vast county with a very wide footprint, and we had long distance travel for some of the lay healthcare workers. We have non-ART sites within the parks, animal parks, and this also posed as a threat. What are we looking at in the future? We see a future with robust community medication refills that can improve outcomes in our unstable patients, especially in our settings, that is the low resource settings. And we need to work around having continued innovation around DSD models that consider unique patient needs and in different contexts. Thank you very much.
Thank you, Dr. Arod. You can take a seat. Next, I just want to check if Dr. Rashid is online. He is online. Not yet.
Services.
All right. We will move on to the presentation from Malawi. And Kelvin, if you're ready, you can go up. Kelvin is a data scientist interested in applying complex data systems into improving health through research, and he has authored a couple of papers. And Kevin is going to talk to the work that they've done in Malawi in characterizing outcomes for men with disengaged care. And we are happy to be joined on stage by his colleague, Sam Piri, who will be sitting on the panel with us to assist to driving the slides. Over to you, Kelvin.
Thank you so much. And thanks, Prof. Sam, for joining. I'll be sharing findings on, sorry, can you project the slides? I can't see them.
We are fine on our side. You can proceed. We can see them. Thanks.
Thank you. To the first slide, please. Thank you. So I'll be presenting findings on understanding maize disengagement from HIV care. And these are preliminary findings from 20 partners in Hope supported health facilities in Malawi. And I'm presenting on behalf of the lead principal investigator, Dr. Catherine Dovel. Before I jump into the main slides, just a word about Partners in Hope. Partners in Hope is a local organization based in Malawi, and currently it's implementing HIV care and treatment program called the client. Named DECO, and the program is being implemented in 123 facilities across Malawi. Partners in Hope also has sub-agreements with the University of California, Los Angeles, and the Lilongwe Catholic Health Commission. In total, Partners in Hope supports over 200,000 clients that are live and working. And then jumping into my main slides, to the first slide, please. We know that men have poor outcomes throughout the HIV treatment cascade. In particular, men are at a higher risk of not engaging in minority, and when they engage, at a higher risk of disengaging and staying out of care. We categorized disengagement into three. We looked at those that have never initiated on minority, those that initiated but were late for 7 the first appointment, and those that defaulted from care. So this next slide. We also identified gaps in terms of what we already know as regards men's disengagement from HIV care, and in particular, what is the actual proportion of men who disengage from care, and what are the characteristics of those that disengage? Next slide. To address these gaps, we commissioned 2 individual randomized controlled trials named the Engage and the Ideal trial. In these 2 trials, we're trying out different strategies that are aimed at engaging and retaining men in care. In total, we have a combined, or we aimed to enroll a total of 1,300 men that were documented as disengaged in care. Next slide. Next slide. So we started off with a review of medical chart reviews. We looked at a period of 24 months, 12 months retrospective and 12 months prospective, to identify and look for men that were documented as having disengaged from care. In total, we identified approximately 1,300 men, and as you can see on the graph on the left, a majority of those that were documented as disengaged were defaulters. We also were not able to trace everyone. So after identifying those that were documented as disengaged, went further to trace them in their communities. We did not use the program's systems for tracing. We had our own independent research assistants that traced these men, and from the tracing, we were not able to reach some. And common reasons for failed tracing were basically inaccurate residential details, others had suddenly transferred out, most others had just temporarily traveled. Next slide. Out of the 1,300 men that were documented as having disengaged from care, we managed to trace 632. As you can see on the left, a majority were disengaged, but we also noted that up to 32% of those that were documented as disengaged were alive and on therapy. These that were alive on a narrative, either they are just transferred out, or up to 46% of those, they were at the same facility, but incorrectly classified as disengaged. Next slide. When we looked at those that had disengaged by the disengagement categories that I mentioned earlier, we picked out some interesting differences. In particular, among those that were documented as having never initiated, we found that up to 50% of those were actually alive on ART, whilst there were small proportions in the other categories, 20% and approximately 30% in those that were late for an appointment or those that had been categorized as defaulted. Next slide. Then, what lessons can we pick from these tracing outcomes? We isolated two key lessons. The first one, that disengagement is overestimated, especially in data, and we think that this is largely because of lack of unique identifiers that can
Sam, are you able to continue for us?
Yes, please.
Thank you.
So I think my colleague here is frozen. So let me just continue to say that I'm sure probably rationing has happened in Malawi too, on power. So many actually who, one of the lessons which we're able to find in this study was that there's, as Kevin said, there was an overestimation of the disengagement. We actually learned that men are doing better than we think in this case. And therefore, we need to have more accurate records and easier transfer systems in order to make sure that we have a true picture of how men and everyone else are doing. And this can be also seen on the other programs. At the same time, okay, we need to make sure that we optimize resource allocation between tracing and system improvement to make sure that the clients who appear as out of care could really be classified as to be part of the treatment car in this component. And also just to mention that programs should focus on how to keep men in care. Initiation currently is not just enough because there have been issues of finding men and starting them on treatment, but we need to make sure that we look at targeting the strategies that can improve long-term care retention amongst the men. So I think I will just be going through the last mile in this case, just some of the characteristics which were found for those men who were disengaged into care in that case. And just to mention in this case that we looked at the demographics for those who disengaged and the history with ART services. And then at this point, we'll just look also in terms of the time since first initiated or time outside care prior to being actually traced in that component. And also, we were able to see some of the patients, in this case, for example, 129 who stopped taking ART, in this case for psychological engagement, who would come and go back and also come back in that component. So men who are disengaged are more likely to also disengage later on. This slide is just, thank you, just emphasizing some of the barriers to HIV care amongst those who were disengaged. And the majority of those, there was anticipated stigma and discrimination from status disclosure. And also about half of them were actually believe that most people experience side effects from ART in that case. And then you had some other characteristics, including not to disclose to, for example, HIV status to anyone besides their spouse. So I think traveling disengaged men, about 32 in-depth interviews were done and hired mobile men. And we were able to see that travel is essential. If we have enough maize, so they're saying if they have food, they can be able, because maize is staple food in Malawi, if they have enough maize, they should be able to actually be able to settle at home and not probably travel. Some of the travel is unpredictable, and so work travel is highly vulnerable in the whims of the employer in that case. And just to mention that men make major efforts to stay in care, but we have seen a couple of issues. They ask guardians to come for refuse. They can also get we may just refuse wherever they've gone, and also they may be able to be returning from travel just to refill for that component. And but as we know that some of them might run out of ART at least once a while. So those who did come back experienced poor rude treatment from providers in some of the facilities. So I think in summary, we're saying 30% of men believed to be disengaged are actively in care, and we know that defaulters comprise the majority of men who disengage from care. And in this case, we're looking at most mid to older age, and also others extended time on ART. So we want to stay, men want to stay on ART, but barriers to care are significant. Some of them are mobility. We're looking at stigma, fear of side effects, and also negative provider responses in that case. So I think the remaining questions are cyclical reality of care amidst massive social familial pressures. Other people would come in and go back. And we want to support, what support do they need to stay in care and re-engage time and again? So we will continue to be looking at this at Partners in Hope to make sure that we finalize this. So I would like to thank, as mentioned, this study was done within our USAID supported program, but also we have some collaboration with the Ministry of Health and also other partners. So Kevin, stay online for the questions coming. Thank you for listening. Thank you.
Thank you, Sam, for rescuing the day. And welcome back, Kevin.
Thank you. And sorry, I apologize. We lost power, so apologies.
We thought as much. We're experiencing the same, yeah. Now we have Dr. Rashid online. Dr. Rashid is a citizen physician in Haiti. He has worked in the field of HIV for the past 10 years and is currently the Deputy Project Director for Epidemic Control among priority populations, and is going to showcase with us the work that they've done among key populations with early refills as a strategy to improve treatment continuity. Over to you, Dr. Rashid.
Good morning, good afternoon, everyone. Thank you for welcoming me. My name is Rashid Dosseville. I'm from Haiti, and I'm working for CEROV Foundation, which is a Asian community-based organization offering free health services to key and priority population, especially men, transgender, female sex worker, and their clients. CEROV also provides free services to men in general and to the LGBTQI population, as well as their families. And as mentioned, today I'm going to talk about the early refill, which is a strategy that we have been using in Fondation CEROV to improve treatment continuity among key population as part of the epidemic control among priority population, currently named ECP2 project, which is a USAID PEPFAR funded project. The abstract title is using the early refill strategy to improve treatment continuity among key population in Haiti from the 1st of July 2020 to 31st of July 2022. But before starting with the background, I want to thank Alain Tirard, our social worker mentor, who led this strategy in the network, and is participating virtually in this meeting. And thanks as well to Steve Laguerre, our project director, and Samuel Jean, our monitoring and learning specialist, who greatly contributed to the abstract redaction. Okay. So I will go quickly in the background. Stay in the slide of background, please. Okay. We all know that treatment continuity is crucial in providing comprehensive HIV care and treatment services and to achieve the 95, 95, 95. However, in Haiti, we are living in a very difficult context, and it's very challenging for the national program to retain patients in care. According to our national health monitoring system in terms of HIV services. National treatment continuity was at 79%. And for the ECP2 network, it was at 80%. So far from the 95 that we are expecting. But we have to mention that the context is very difficult in Haiti. So we have a very difficult socio-political context in addition to COVID-19. And you all know that KP are very mobile. We are living in a very economic condition. So all those factors give us this poor continuity in treatment. So we had to find an adequate solution to address this situation. And among the strategy that we came with, we are presenting this morning the early refill strategy. Next slide, please. So what is the early refill strategy? The early refill strategy is the fact to provide the patients with medication approximately 1 month before their appointment date. So that means if the patient have to come in July 1st, so we make sure that 1 month before this date, we call the patient and we talk with him and propose him to provide him with his medication, either in the community or if he wants to come in the facility to get this medication. And how does it work in the facilities? So every month, the psychosocial unit draw the list of appointments, and together with the clinical team, they clear the list to see and to remove the patient who are not eligible to receive the medication in the community, or to remove the patient who have to come in the facility for a special follow-up. And after this clearing, they also go in the dispensation unit to ensure that there's enough drugs to supply this patient. And if there are enough drugs to supply the patient, so the psychosocial unit take the list of patients who have to come, and they allow to the peer navigators a cohort of patients that can go from 20 to 40 patients. And the peer navigators call those patients, and they confirm with us their availability, and they confirm with us where they can meet with us to give them those medications. And if everything is correct, so the peer navigators go in the field and they bring the medication, including ARVs, including drugs for opportunistic infection. They bring all those medications to the patient and give them to the patients. But To implement this strategy, it is very, very, very important to make available adequate tools to monitor the expected visit and to manage the stocks in order to avoid stockouts. In our network, we use the EMR system to find the list of eligible patients, and the psychosocial unit make the breakdown manually and do the follow-up with the peer navigators.
Dr. Rashid, do you have a minute to go?
Yes, okay. Next slide, please. Then, what did we learn from this experience? As I mentioned earlier, this strategy was implemented between July 2022 and from July 2020 to July 2022. And during this period, we had to supply 8,895 clients on ARV. So the providers use the early refill strategy to supply 40% of those clients. And it was very easy and grateful because we ensured that all these patients was returning in care. And what we saw, only 17% of those patients return in care on the appointment date by themselves. And while 43% missed their appointment or became in treatment interruption. So we concluded that the early refill strategy can contribute to improve treatment continuity and prevent treatment interruption because more the clients are receiving a 6-month supply MMD 1 month before their appointment. So the more they will be returning in care. So until now, we continue to use this strategy, and this helps to improve our treatment continuity. And now we're almost at 90%, and we will continue to use this strategy in order to achieve our goal, which is the 5%. So thank you. We're here for the question if you want to know more about the early refill strategy. Thank you.
All right, thank you very much, Dr. Rashid, and let me also thank those that presented our first two presenters. We'll quickly go into questions because of our time, and I will just take one round of questions for all of our presenters. Let me start with Susan. You mentioned several interesting drug delivery models. Can you describe the differences between them and how these DSD models were chosen as potentially effective ones for unstable clients?
I think I may have mentioned in one of the slides that the models were based on client choices. So we would give the client information, including the models that are available, and they will choose based on need and ease for them. There were those who had stigma and did not want, to be seen. Do not want to see, the lay workers coming to their houses. So they would prefer to go into the non-ART dispensaries to pick their drugs, because that way it remains anonymous and no one would know. And then there are those with younger children who are, who preferred to have the drugs delivered to them. So it was purely patient choice.
Thank you very much for your response. Let me go to Malawi. Kevin, Kelvin, I hope you are still online. Anyway, you have a backstop in case. Let me take this question, particularly on the issue of stigma, because that was a major challenge that we could see, as part of the reason why quite a number of the men perhaps were not accessing. So what have you tried to do to help men with disclosure beyond partners and social support when it comes to the issue of stigma and disclosure? What exactly has been done? Kelvin, can you respond to that? Seeing that as a major challenge from your presentation.
Thank you. Indeed, one of the barriers that was common was stigma. And so these findings, as I mentioned, are from randomized control trials. So I will speak specifically from the perspective of randomized control trials, and I'll ask Prof. Sam to chip in also in terms of what PIH as a program also does in terms of issues of stigma. For these two trials, what we've been doing is that we've been providing client-centered counseling, one, to understand what really are the issues that are being reported as regards to stigma. Just to highlight that what we found as the most common stigma is not necessarily stigma that has been experienced, but it's what we call internalized stigma. So people fearing that they will experience this kind of issues. And so our counseling was now basically aimed at, okay, how basically can they overcome these concerns? These concerns to say, if I disclose my status, I'm going to be stigmatized, and then I'll have these different experiences. So we try to provide specific counseling on how these men could overcome these concerns of stigma. But as regards stigma that has actually been experienced, these ones we work hand in hand with programs, and so I'll refer to Prof. Sam to shed more light on what PIH does as regards dealing with such issues.
Do you have anything to add?
Thanks, Kevin. So I think what I would just say is that for Partners in Hope, as we're looking in terms of the stigma, for those who are out there, it relies on the national program and also the community programs, which will be able to look at demand creation and also some issues around the stigma index reduction. So as part of the program at Partners in Hope is that for those who come in for testing, those who are positive, including men in that case, they will be assigned to case managers. And these case managers are able, along with psychosocial counselors, are able to actually work with them throughout for the 6 months to make sure that they are actually giving them a lot of counseling to come back. So we are now utilizing these men as champions when they go out, because they would say, okay, if you go to the facility, you start on treatment, you will be much better. So availability of drugs and also the response to the treatment is also another strategy that works out for the reduction of stigma amongst the men. I'll stop there for a moment. Thank you.
Great. Thanks for your response. I know in the interest of time, I would have loved to go to Dr. Rashid, but maybe if we could ask 1 or 2 questions from the audience, if there's anyone with burning question. Maybe you can just take 2. Yes, quickly. Okay. Please, can you come on? So, Dr. Rashid, just stand by in case if there's any question for you.
Yeah, thank you. My name is Dr. Kalugila from Tanzania. Thank you for both presenters, and mine I will want to direct myself to the study in Kenya. We see less men are being engaged in this, whereby majority were females. Could be that the male were not accepting the model, or is the population which is being saved. And for Kevin, we see silent transfer. And could you associate with what we had from Prof in the meeting this morning about the documentation and improving in terms of monitoring? Probably those are the one on care, but we happen to term them as transfer out. But again, we see among those who were never initiated, a few, almost 21%, found to be not alive for those who were initiated but never returned. Maybe if we can explore more what is happening to those. Could be those early death because maybe they were initiated and happened to die. I think that could be an area which we can explore more and find what is happening on that. Thank you.
One last one, I think. I'm not sure we have the time.
Yeah, thank you so much, moderator. Juko Richard is my name from Uganda. And thank you so much, the panelists. I have one question, and it goes to Dr. Susan. You spoke about the community medication refill, which I love passionately. My question is concerning data management systems at community level. How did you manage that, and also any issues in the management of stock and commodities at the community? Thank you.
So let's give our presenters the time to respond because of time.
Okay. I'll respond to let me start with the first question. So in terms of men, you realize that we have different models of DSD, but for this particular DSD model, and of the 52 patients that we have, I think it is when we characterize the patients, that is what came out, that we had more females. However, looking at our program, we generally have more females than more males within the HIV program. But that is not to say that we do not have male engagement, and we continue. We are not where we want to be, but we continue to engage men in various other models. So we have other differentiated models where we have men-only groups. We also have men-only clinics that we are engaging men. And this is something, this was a pilot. It was just a 6-month implementation, but we take that into account, and thank you for that. So for the next question, it was around community ART refill data management. So we had tools that we are using. We have, the first tool is a community, the ART refill tool that is given to the lay workers as they go for refills. And then we have the community ART registers that they also use. So once they have this, so the ART dispensing tool is brought back to the facility by the lay workers. So it is filled in 2 sections. I think it's a common tool that we use across different programs. First section is for the prescriber, and then the second is for the dispenser. So that way we get the tools. Then we also have the the register for the community ART registers, and we also have the appointment diaries where we monitor retention and appointment keeping. And as we mentioned, all these are brought back to the facility, and these are entered, transcribed into a DHIS instance that we have created that we use for precision programming. Thank you.
Can we have a quick response from the Malawi team?
So quickly, let me take this silent transfer question. So there are key drivers for silent transfers. To begin with, we start with a success of the scale-up program, opening up of new clinics. Patients would just go to the nearest clinics which have just opened. And because we do not have the interoperability linkage that we would find in the country already to say, ones who has moved from one facility to the other, if they get medication, that we can update on the other side unless they come back. The other component is, as you mentioned, that's true, that it is a documentation issue. They may have taken a transfer, but probably that was not documented properly. But in this case, the main driver is that there are several clinics which are opening, several initiatives, including actually community programming that are doing that. And finally, as we mentioned about non-starters, and also, because these are the people who are labeled as they have started, they will get the medication, but
when they went home, they did not start the medication in that component. And of course, yes, if we have people who are like in the advanced age, stage of disease, they may have died in that component. So we're able to characterize some of those into the study. So I think that's what I would say for now, and I hope, Kevin, I did justice to that. Thank you.
Thank you. A round of applause to our presenters, please. And thank you all for participating in our session today. And please stay tuned for the next session, which is more exciting. Thank you.